Voilà, Bernard.
Tu as vraiment une belle vue derrière chez toi.
So, I think we can start, Bernard. Hello, everyone, and welcome for this new DXBone Forum session with live streaming on YouTube. For people, first of all, my name is Philippe Landreau. I'm Chief Medical Officer of DXBone. And thank you for attending our broadcast. For those who are here for the first time, I would like to tell you that this program, it's every 2 weeks now, is done to maintain our educational platform interaction with all colleagues, surgeons, but as well physiotherapists, nurse, and any other doctor interested in the field of orthopedic and sport medicine. You must know that this is live, but it will be available on our DXBone channel, so you can subscribe to be able to see all the video already done and all the presentation performed by the DXBone team. And you can ask some question, on the window chat. If you log in correctly on YouTube, you can ask the question, and at the end of the presentation, which will be between 25-30 minutes by Dr. Bernard Lallemand, we will be able to answer to the maximum of your question. Today, I'm again happy to welcome one of our consultant specialists, Dr. Bernard Lallemand, who is, as you know, probably a specialist of upper limb and hand and wrist and elbow, and he has a large expertise. He used to work in Belgium, in France, in Luxembourg, in Qatar. This is where we met in Aspetar. He has extremely important experience, and his skill and expertise have no doubt, and this is why he joined DXBone a few months ago. And today he will talk about something which is a very practical topic, the finger sprains and dislocation. I think it's very interesting for everyone to know how to recognize them and how to manage them. And I'm even very happy that we wear our new DXBone t-shirt. Difficult to know, but we're very proud with that. I have the black one and Bernard the blue one, so we wanted to celebrate that with this DXBone forum. Bernard, you're online, you have the microphone, the podium. Thank you very much for your time, and you can share your presentation and your screen, please.
Thank you, Philippe. So thank you for this introduction, Philippe. And yes, we will discuss about a topic that look like quite easy. I will discuss about the finger sprains and the dislocations. I have no conflict of interest for this presentation. So the introduction for today is about the finger sprains and dislocation. You should know that the injury of the finger are quite common in daily life activities and in sports, and it must be seriously taken in charge. Why? Because the spectrum of these injuries varies from the minor sprain to the complex intra-articular fracture. The severity of these injuries are often underestimated by the patient and some physicians. And the management must be proactive to restore the mobility as soon as possible to prevent the stiffness and disability. So in 2012, a beautiful epidemiology study was done in the United States based on the upper extremity injuries that present to the emergency department during the last 10 years. And the incidence of the finger sprains was 37.3 per 100,000 persons a year, and for the dislocation, 11.3 per 100,000 persons a year. This article said this number should be underestimated because some of the patients were not present to the emergency. So if we put this on the UAE, it represents almost 3,600 finger sprains a year and 1,100 finger dislocation a year. It's almost 13 to 15 injuries every day. So what is a sprain? A sprain is a stretch or a tear of an inner ligament. And the ligament, as you know, is there to stabilize the joints. Should not be confused by the strain. The strain is a stretch or a tear that happens in a muscle or a tendon. In 1953, Murbeck and Stener present a beautiful study about the tensile strength of the ligament in the joint of the hand. And you see that you need 36 kilo to have a rupture of the ulnar collateral ligament of the MCP joint, and 43 for the radial collateral ligament of the index. The symptoms are quite the same for all the joint: pain, swelling, tenderness when pressing over the injured ligament, and some difficulty to move the finger. The classification of the sprain are the same for all the injury and all the joints. It's based on the severity of the injury. The grade 1 is a mild sprain. You have a slight stretching and some damage of the fibers of the ligament, but the ligament stays grossly intact. The grade 2, moderate, you have a partial tearing of the ligament, and it could have you could find some abnormal laxity in the joint in certain way. And the grade 3 is severe. It's really when you have a complete tear of the ligament and you have a significant instability. For the dislocation definition is an injury to a joint in which the end of the bones are forced from their normal position. And the most two common dislocations are the shoulder and the finger. The symptoms of the dislocation is swelling. You can have a deformity of the joint. You have numbness and tingling because the ligament could be, the nerve could be stretched, and you can have difficulty to move the finger, what seems obviously in this case when you have an open dislocation of the PIP joint. The classification, there is no real classification for the injury of the hand. I used the AO Foundation dislocation, and you have a number to identify the exact joint involved, and then you have another number to say the direction of the dislocation. The direction is always the distal bone relative to the proximal bone. We will discuss today about the DIP joint of the finger, the IP of the thumb. We will discuss about the PIP joint of the long fingers. There is no PIP joint in the thumb, and the MCP joint of the long finger and the thumb. So the DIP joint of the long finger and the IP joint of the thumb are based on the middle or the proximal phalanx for the thumb and the distal phalanx. And the base of the distal phalanx is wider than the head of the middle phalanx. Concerning the soft tissue, you will see that you have the collateral ligament. You have always two collateral ligaments, one principal, one accessory, who is attached on the volar plate. You have the flexor tendon, and you have the extensor tendon. It's really important to know the anatomy of this joint because it will give you the mobility of the DIP, a flexion of 90 degrees and extension of 30 degrees. The DIP joint sprains are quite a rare occurrence, even in active athletes. The low rate of occurrence may be due to the stability of this DIP joint compared to the PIP joint. And this stability is primarily imparted by the extensive adherence of tissue, as I showed previously. The pain, I explained that the pain are classical. You need to do an X-rays because before making the diagnosis, it's a DIP joint sprain, you need to exclude any soft tissue injury and bone injuries. It's difficult on a swollen DIP joint to say it's a DIP joint without X-rays because it could be a fracture of the distal phalanx, it could be an avulsion, a bony avulsion, a mallet finger of this DIP joint, or it could be a jersey finger. Concerning the dislocation of the DIP joint are rare and usually dorsal or lateral. As you can see here on these X-rays is dorsal, and this DIP joint is a lateral dislocation. And these dislocations are often associated with an open wound. The treatment of the dislocation consists to a close reduction except for the open injuries under digital block anesthesia. The reduction is done by a longitudinal traction with a direct pressure of the dorsal part of the distal phalanx and then a mobilization in flexion of the distal interphalangeal joint. When the DIP and the thumb IP are irreducible, you need to go for surgery because you have probably an incarceration of the volar plate. The rehabilitation is standard for the DIP joint and the DIP sprain, as I will show you here. First, for the dislocation, always do a post-reduction radiography to confirm that the joint is reduced correctly. After the reduction, you will apply a DIP splint for 1 week. After the first week, you will start the active range of motion 10 times an hour, 6 times a day. And you will start to do some desensitization exercise. After 3 weeks, you need to do some passive range of motion to recover all the mobility. And the strength is started after the 4th week. Sometimes you can have multiple joint dislocation. It's quite rare. So now we will discuss only about the long finger concerning the PIP joint. The PIP joint are really important joint, and they are relatively common in the practice of a hand surgeon. The PIP joint is normally a stable joint because you will find the lateral ligament on ulnar and radial side and the volar plate. And dorsally, you have the capsule. So it creates like a box. And as you know, a box has 4 slides and is quite stable to the deformity. So the collateral ligament of the PIP joint are at the number of 3. You have the main collateral ligament that is attached from the lateral side of the proximal head to the base of the middle phalanx. You have the accessory ligament which is attached on the volar plate, and you have an accessory phalangoglenoidal ligament. What is really important is that these 2 ligaments, the 2 first ligaments, are tied in different positions of the joint. The accessory ligament is tied when the joint is in extension, and the principal ligament is tied when the joint is in flexion. Palmary, you have a strong fibrocartilage plate that is extend from the palmar side of the neck of the middle phalanx, the proximal phalanx, to the base of the middle phalanx. There is 2 check-rent that you can see in blue. They are coming from this volar plate, and they are attached on the A2 puli. And the palmar plate resists to tension up to 19 kilo. It's more important than on the MCP joint, where the tension load, the resistance is about 10 kilo. So if you look at PIP joint, is a really complex joint. You have the volar plate, you have the ligament, you have the flexor tendon, dorsally, the dorsal capsule, and the central slip with the lateral band of the extensor tendon. The range of motion is between 0° extension and 130 in flexion. So the PIP joint sprains are the most common injuries in hand-focused sports like basketball, volleyball, handball. But you can find this to any sports when the athlete fell down. To understand these PIP joint injuries, you need to be familiar and to know exactly the basic anatomy of this PIP joint, as I just explained to you. So the symptomatology, always the same. You will find some pain, some swelling, tenderness to the palpation of the injured ligament, and you can find some mild instability that you need to test during some stress tests. So X-rays are mandatory. You need to do minimum 3 views, AP view, a true lateral view like here, and an oblique view to see if there is any associated ligament with this sprain. So the rehabilitation, I like to apply a DIP joint digital splint when the joint is really painful for 1 week with some Lycra digital tube compression to reduce the swelling. To active range of motion is started soon as possible to avoid any stiffness. Sometimes, especially for the lateral sprain, I like to put some syndactyly with the adjacent finger to avoid any stress during the mobility. Now we will discuss about the PIP joint dislocation without fracture. And you can have 3 directions: the dorsal dislocation, the lateral medial or lateral ligament, and the volar dislocation. We always use the middle phalanx compared to the proximal to define the dislocation direction. So the dorsal dislocation is a hyperextension injuries with some compression, most likely like when you have a ball striking in a fingertip. In pure dislocation, the collateral ligaments are torn, but after the reduction, their function is still intact. And you have a volar plate rupture, usually at the base of the middle phalanx. You have 2 types of dorsal dislocation. The type 1 with an injury in hyperextension with still some contact between the proximal head and the middle phalanx basis. It's like a subluxation. And this type 2 where you have the sign, the bayonet position, as you can see here. The reduction of the stage 1 is quite easy. You need to do traction and with pressure of the distal middle phalanx volarly on the digital block. In a Bouttonière deformity is a little bit different. You need to do an hyperextension of the joint and then apply some volar pressure on the middle finger and flexion of the PIP joint to reduce this joint. The rehabilitation is quite the same than for the sprain, so except that you respect the pain a little bit more. If you have after 3 to 6 weeks some PIP joint flexion, you need to apply some DIP splint like this Kepner to restore the PIP joint extension. So the lateral is a critical anatomic lesion, because you need to have, for a lateral dislocation, minimum 1 collateral ligament rupture associated with a partial or total avulsion of the volar plate. As you can see on these X-rays, it's not, you cannot explain only with a complete tear this instability. I remember you, the PIP joint is a 4 box. To create this kind of instability, you need to break minimum 2 or 3 sides of this box to have this instability. The reduction is done on the longitudinal traction and the reduction on the digital block. I love to place syndactyly with the finger of the side of the injury to avoid this stress injury on this ligament. Sometimes the joint is irreducible or partially reduced because there is an interposition of a lateral band of a collateral ligament. It's important to do the X-rays after the reduction. It's really important also to follow this ligament, because sometimes after 4-6 weeks you don't have a good repair, and like in this case you can keep some instability, and you need to repair this ligament with small micro anchor to repair the principal ligament part of the volar plate. The volar dislocation without fracture are rare injuries. You have 2 different volar. You have the pure volar dislocation without rotation, like in this case, what we call the volar dislocation. And you can have a rotation because one of the ligament persists intact. And you can see here the volar with some rotation. And this, in this case, you could have some interposition of the sagittal band of the extensor tendon, like in this case, when you need to do an open reduction to reduce the joint. The closed reduction could be tried on the digital block, And when you did the close reduction, you need always to assess the central slip of the PIP joint, because if you don't control the central slip of the PIP joint, you will have what we call a Bouttonière deformity due to the loss of the extensor mechanism in zone 3. And it's a flexion of deformity of the PIP joint with a hyperextension of the DIP joint due to the subluxation of the triangular ligament, as you can see at this level. So how can you check after the reduction? With the Elson's test, you place the PIP joint in 90 degrees and you ask the patient to make an extension of the PIP joint. If the central slip is competent, the DIP joint will stay in flex position. If the central slip is broken, you need you will have an hyperextension of this DIP joint due to the continuous traction of the extensor tendon on the lateral band. So you have another test that's called the Schneider test. This is a handball player who fell down and had a volar dislocation, and you can see after the reduction that the DIP joint was in extension, and on the left side, the DIP joint stay on the slight flexion. I will explain for all the people an example after my presentation. So, and sometimes the dislocation of the PIP joint could be terrible. You can have a dorsal lateral ligament dislocation with open injuries. So this dorsal and volar dislocation can be sometimes associated with fracture. And there is this classification described by Schenk, but I prefer to use this classification. Less than 30% of the palmar site of the base is a stable fracture, 30 to 50% is a tenuous stable fracture, and over 50-60% is an unstable fracture. For the stable fracture, you treat them like a PIP joint dislocation. For the unstable fracture, you can use this external fixator to maintain the traction with a ligamentaxis. So it's called ligamentaxor external fixation with good result after 3 months. If the fracture is more important and it's a fresh injury, you need to repair this injury through a gunshot approach with small screws and a cerclage. And sometimes when the joint is not possible to be reconstructed in emergency, you need to go on the Hamad to take osteochondral graft to recreate the palmar side of the base of the middle phalanx. So the volar dislocation with fracture are more rare than the without fracture, and you need to reduce this dislocation, but you need to fix the small fracture because, you know, in this case, you have automatically Bouttonière deformity because this is the avulsion of the central slip. That's it for the PIP joint. Now we go for the MCP joint. So the MCP joint ligament, you have, like for the PIP joint, a strong principal ligament and an accessory ligament, and they are tied in the same position than for the PIP joint. So the range of motion is about 90 degrees in flexion and 40 degrees in extension. But you can have some abduction and adduction in this joint. So the ulnar collateral ligament is rarely injured in the MCP joint. Usually it's a radial collateral ligament because the mechanism of injuries are forced ulnar deviation with an MCP joint in a flexed position. X-rays should be done with a special view, the Breverton view, that permit to view correctly the MCP joint. And a magnetic an MRI should be done to identify the nature and the location of the ligament. As you can see here, a proximal avulsion of the radial collateral ligament of the middle femur. The treatment, I love to place this joint in 30 degrees of flexion for 3 weeks before starting an active rehabilitation with a syndactyly. So the treatment should be started as soon as possible, but you need to explain to the patient that the joint will be stable quite fast after 6 weeks, but the pain and the forceful gripping may take minimum 1 year to recover. And if the pain persists or there is instability after 6 weeks, or if you have a grade 3, like in this case, injuries, you should repair this ligament directly to have a good results. So for the dislocation, you have two kinds of dislocation, the dorsal and the volar dislocation. You don't have a lateral dislocation on the MCP joint on the femur. So you have two dislocations, the simple and the complex one. They could be seen by the during the X-rays. And it's really important to understand the anatomic distinction, because you can easily, by doing a wrong maneuver of reduction, transform a simple to a complex dislocation. So the subluxation, the single incomplete dislocation, you will have still a little contact. You will have a hyperextension of the MCP joint, and the volar plate is still draped over the metacarpal head. To reduce this joint, you need to place the wrist in flexion and to apply volar pressure on the dorsal side of the proximal phalanx. In the complex joint, you have complete rupture and interposition of the volar plate between the proximal phalanx and the head of the metacarpal. If you cannot reduce this dislocation by close reduction, you need to go for surgery, because you can have an interposition of the flexor tendon or of the palmar plate. For the volar dislocation, extremely rare. You can try to do a close reduction, but you have sometimes the interposition of the dorsal capsule, and you need to do a dorsal approach to reduce this joint. Let's go for the thumb, our last joint. So the ligament of the MCP are quite the same than for the MCP joint of the finger. You have one principal, one accessory, and the phalloglenoidin that is attached on the sesamoid bone. We have discussed about the skier thumb. You know, it's an acute rupture of the ulnar collateral ligament. What is really important is to see that if there is some Stener lesion, because the Stener lesion is the complete tear of the ulnar collateral ligament with interposition of the adductor pollicis aponeurosis. On clinical examination, you will see around over the ulnar side of the MCP joint. It's a sign of a Stener lesion, and you need to test the laxity of the MCP joint. X-rays are mandatory to see if there is no bony avulsion, and ultrasound could help for the Stener lesion, and the MRI is really the best imaging to see the rupture, the partial rupture, complete rupture, or the Stener lesion, as you can see on this MRI. Grade 1 and 2, static thumb splint for 4 to 6 weeks. And for some patient without Stener lesion, the grade 3 could be treated with the same principle. You have here the full list of the rehabilitation. I don't recommend to start the strengthening before the 8 weeks or the 12 weeks, depending if there is fracture or not. Personally, the grade 3 without Stener lesion for the athlete are operate, because the results are better. And the grade 3 with a Stener lesion, like in this case, should be operated immediately. The radial collateral ligament tear is much less common than the ulnar collateral ligament tear. The diagnosis and the treatment are similar. You can have on the X-rays some volar subluxation of the proximal phalanx, and the tear is more usually on the proximal side of the radial collateral and on his attachment of the first proximal metacarpal head, sorry. So now we will discuss about the dislocation. Most of the dislocation of the MCP joint are volar. It's an hyperextension injuries with a complete rupture of the volar plate. This rupture could be through the sesamoid bones or distal at its attachment of the proximal phalanx, but most of the time it's happened proximally. And this will give a problem that I will show you directly, because the diagnosis, it's quite easy. You will see this hyperextension MCP joint with an adducted first metacarpal and a flex IP joint. And this is because the injury happens in the proximal part. You can have this incomplete simple dislocation when the MCP joint with the sesamoid are wrapped over the first metacarpal head, or a complete dislocation like for the MCP joint of the finger. The radiography shows typically the hyperextension of the MCP joint. You can see the interposition of the sesamoid bone in a case of a complex dislocation, and this situation will be really difficult to reduce by close reduction, and I suggest to refer directly for a hand surgeon to do an open reduction of the joints. If you have a simple dislocation, you need to do the far above maneuver. As I show you, you need always to try close reduction before going for surgery. So the maneuver of far above is a simple longitudinal, it's a hyperextension of the MP joint with a direct pressure of the thumb, my thumb here, on the base of the first, the proximal phalanx. And you will try to drape the volar plate and the sesamoid bone over the metacarpal head. So you will try to go from a complete to an incomplete dislocation, and then you will do the simple longitudinal traction and direct pressure to reduce this incomplete dislocation. So as you can see, the difference here, it's an incomplete dislocation. You see there is a slight hyperextension, not really Bouttonière deformity, but you have still this IP joint flexion, and you see here the maneuver of far above to reduce this joint. You push, you apply directly the force, and then you place the MCP joint in flexion to reduce the joints correctly. The volar dislocation are really rare. It's less than 10% of the MCP joint dislocation. Like for the MCP joint, it's a direct dorsal traumatism on the proximal phalanx. And most of the volar dislocation could be reduced without surgery. But again, if you cannot reduce correctly the joint, it's because you have an interposition of the dorsal capsule or ligament. To conclude, finger sprains and dislocation are quite common injuries. They are often managed by family physicians, sports physicians, and some physiotherapists on the ground, on the field. So a systematic physical examination should be done to avoid any complication and poor outcomes like stiffness, Bouttonière deformity, residual pain, instability. Radiography are mandatory or with 3 views, epi, true lateral, and oblique view. You need to refer to the hand specialist if the dislocation cannot be reduced, or if there is still an instability of the reduction, because you can have ligament injuries, soft tissue injuries more important than expected. And if you have a fracture and this fracture is unstable, it's required to refer to a hand specialist within the week to see if there is a necessity to perform a surgery and to stabilize this joint. So these are the reference from the picture are coming for these 2 beautiful books. And I didn't speak so much about the skier thumb, so I invite the people who never seen the first lecture done by myself 2 months ago on our YouTube website. Thank you so much.
Thank you, Bernard. It's a great overview, very helpful. Probably it's a bit difficult for people who are not specialists to digest all this trauma, particularly because I believe that each trauma is studied in detail by you guys, the specialist of hand and wrist. But I think the message and the purpose of this presentation is to give some guidelines for the people who are not specialists to know what to do. When you said that sometimes we can refer to hand specialists and so on, I believe, in my case, I'm not hand surgeon. I know how to manage the grade 1 and grade 2, but I think it's important to always have an opinion and an expertise by a hand surgeon, because it's quite difficult, and it will bring to my question later on, quite difficult sometimes to know what are the trap, you know, sometimes a combined lesion that you could miss, or what are the surgical indications sometimes to avoid the sequelae for the patient. What do you think about that?
Totally agree with you. First, all the PIP joint sprains are quite simple, even for the reduction. The only thing sometimes we need to reassure the patient, because people consider the finger sprains like a small, simple injuries, but what they don't know, it can stay painful and stiff for 3 to 6 months, even 1 year for some joint, as I explained. So when you have the experience, you can say to the patient, listen, trust me, you will have pain for 3 to 6 months and you need to accept it. This is for the simple things, but there is sometimes some complex injuries associated, and it's why I try at the beginning to do this lecture to make understand that even it looks simple, a sprain in a finger, it's not always simple. It could be terrible. And if you miss tendon injuries like for a central slip, or if you keep some instability, the result will not be the same if the patient is coming to a hand surgeon after 3 months than if it was after 1 week. Sure. So I'm there for that, but I will not see all I think it's quite a little bit similar like the ankle sprain. The orthopedic surgeon specialized in the ankle should not see all the sprain. The grade 1 sprain should not come directly to the hand surgeon. But if there is anything that is not looking normal, yes, we are there for that.
Yeah, I think it's a great message. And by the way, you mentioned the long outcome, you know, that we can see on the. I have a few questions from me and from a direct question sent by WhatsApp, by the way. You know, in the simple sprain, I'm not talking about the complex one, the simple one, grade 1, grade 2, or we see sometimes a long evolution with swelling, pain, and so on, and particularly swelling. You know, the people say, oh, it's incredible how this joint is swollen after 2, 3, 4, 5 months. In general, I know that sometimes it cannot be avoided. What is your best option? What is the best option? How to minimize, as we can, this long process of swelling, which can be annoying for the patient? For grade 1, 2, you know, the non-complicated.
Yes, the grade 1, 2 should be directly with digital tubes for the DIP and PIP joint, not for the MCP, unfortunately, you cannot use. But for PIP and DIP joint, to place directly after the injury some comprehensive bandage or digital tube in lycra or silicone to reduce the
compression. For compression.
To make compression, yes. But it's you cannot avoid this swelling. The typical case are the rock climber, when not about the pulley injuries. They have a lot of sprain of the finger, and they have this knuckle on all the finger because it happens so regularly. So it's quite difficult because not like a knee, I will say, where you have a lot of muscle and fat surrounding the knee, you don't have a lot of fat around the finger. So if there is a thickening of the ligament, this thickening is a part of the healing process and it will stay forever. So you need to treat it directly, because to treat this after 3 months, it makes no sense. And usually I say to the patient, the swelling, you need to wait minimum 6 to 12 months to see the final results.
Yeah. And so this is for the grade 1 and grade 2. But in general, I know it's difficult to summarize. But if we talk about the grade 3 sprain, so the severe sprain, we don't talk about dislocation, but sprain. Can you summarize what are the surgical indications based on the lesion, the finger, the sport, different criteria? Is it possible to roughly summarize for the audience?
So simple. I will not operate directly grade 3 for PIP or without dislocation for a PIP sprain or a DIP sprain, because there is no common retraction of the ligament. As you can see, you have 2 ligaments, and it's rare to have both ligament injuries, except if it's proximally. I will always examine my patient after 6 weeks if there is any instability, especially for the lateral sprain, for the ligament lateral, because there is the volar plate also. And if there is an important instability, yes, maybe we need to go for surgery. So the MRI will be done, and the MRI will show if there is some healing process or if the ligament is completely detached from the bone and will not heal the bone. So the MRI will help me after 6 weeks usually. The other thing is the grade 3 of the volar plate. So for the volar sprain, these are really common, even without any fracture of the middle phalanx. So these are really important to follow, because the volar plate can retract and will give some residual flexion of the PIP joint, especially rarely on the DIP, but commonly on the PIP joint. And the proximal interphalangeal dislocation will be stuck in 20-30 degrees, and it's important to place some Kapner splint, dynamic extension splint of the PIP joint after 2-3 weeks. So it's important to follow this patient.
How long you can wait reasonably? I mean, how many days you can wait to do the treatment if there is a surgical indication? After that, you can talk about chronic problem.
Except for the MCP joint of the thumb, when you have a Stener lesion, you have rarely retraction of the ligament. It's simple, the ligament doesn't heal, so you can wait.
And in comparison, because, sorry, yeah, go ahead.
But if there is a Stener lesion, like the collateral ligament, the ligament is bent and will retract, so you need to do it.
It's an opportunity to answer to compare with the tendon, because Dr. Fetty asked this question in a finger tendon rupture, which is what is the appropriate timing for tendon repair. So we talk about the sprain. Now for the tendon, how much time we can wait?
So for the flexor tendon rupture, it's only the jersey finger. I have discussed about this, but if the tendon is cut directly, the extensor tendon is totally different. The extensor tendon are not retracting in the finger, because the anatomical disposition of the extensor tendon make that there is no big retraction.
So you can do a primary repair until 3 weeks, 4 weeks?
It will be primary repair is always when it's in urgent within the week. After that, it's a secondary repair. But yes, I operate recently 2-3 weeks extensor tendon, and I have a retraction of about 3-4 millimeters, not more.
Yeah, so it's not the perfect situation, of course. By the way, you mentioned 2 times the Stener. Yeah. We know that for the thumb. Is there other? I know that we have a Stener effect with the MCL on the knee sometimes. We call that the Stener effect. Is there another finger, another joint than the MCP?
So yes, you can have on the radial collateral. It's more rare, but there is a structure that can create these Stener injuries, but it's relatively rare compared to the collateral. And on the MCP joint, I show you one patient with a grade 3, and she had a Stener effect because the ligament was over the sagittal hood of the extensor tendon. So it was not possible to heal. So it could happen on the MCP joint, but PIP, no.
Yeah. When you talk about the chronic thing and the persistent instability, is there, like for a shoulder, because you mentioned the shoulder, is there, does it exist to have some recurrent dislocation of some joint on the hand, because there is so big instability that it make recurrent dislocation, and what to do in this case, and which one are the most frequent?
It's why when you have a big instability in a joint, you reduce usually the joint by close reduction under local anesthesia. So you can manage and see if there is any residual stability after the dislocation, especially for the PIP joint. But yes, you can have some recurrent instability, and then you need to repair the ligament. We don't have any Latarjet procedure for the fingers. And it could happen also for the volar dislocation, the dorsal dislocation, when you have some fracture associated, and you know that over 50%, even over 30%, you can have some instability.
And so, which one in this case, in the recurrent dislocation, which joint is the most frequently?
The PIP joint.
PIP joint?
Yes.
Yeah. About the return to sport after a sprain, I know it's difficult again to summarize for different joints, but roughly, and can you give us an idea about, you know, for example, we have some sport physicians, physiotherapists who are here. I'm sure they're interested to know that. What can they tell to their athlete, depending on the type of activity, but I mean, when they play with the hand, after sprain 1, 2, sprain grade 3, and dislocation, what is the time to return to sport usually?
But it's really depending about the player. You know, one of the most beautiful ball sports, the volleyball, how many dislocation of the PIP joint they have, they reduce themselves on the field and they go back to play after strapping. If you see the handball player, the volleyball player, the basketball player, they all have strapping to sustain all injuries of the PIP joint. I think it's quite difficult to say to a patient without surgery, you need to stop for 4 weeks, 6 weeks before going back for your activity. They will not accept this. These are small joints and they are ready to lose some, you know, to have some pain, to have some swelling, because this is the most problem also. And the high level athlete will go back to the sports directly after. The thing is, if you do a surgery, yes, it's a little bit different. But again, you can, with some splint, with some strapping, let them go back really fast on the game. So you need to see the patient, the volleyball, handball, and basketball differently than football or rugby.
Yeah, sure.
But no, they go back really fast. They reduce themselves.
Interesting question again from Dr. Fetti. Can you talk about the chronic Stener?
So the chronic Stener,
what are the outcomes? What can we promise to the patient or not? Okay.
So it's totally different. When you operate a patient with a chronic UCL with Stener lesion, sometimes it's impossible to repair directly with the ligament. Even you do some plasty of the ligament, it's impossible. So you need to take a palmaris longus and you do some new ligamentoplasty to recreate this collateral ligament with, for example, the palmaris longus. It's what I discussed last time. It's called the gamekeeper when you have these chronic injuries, and there is a beautiful surgery to perform for this reconstruction.
You talk about the palmaris longus. Yes, go ahead.
Yes, for the return to play, minimum 2 to 3 months.
Yeah, you talk about the palmaris longus when you do a plasty. Is there a place for the? I know that you don't need a big amount of tendon, so we can always find on the palmaris longus. Do you Is there a place for some allograft tendon, small tendon, in case of chronic and severe instability?
No.
Of the finger?
No.
Usually you can find
you know, you have the palmaris longus, you can take a part of flexor carpi radialis or the retinaculum. So in hand we have everything on place.
Yeah, it's easy.
We don't take a lot of allograft.
Yeah. And when you mentioned the volleyball player, they you know, when they play handball, and we always see that they have some strap protection. So it's frequent in this kind of sport. Is there or are there efficient way to prevent this lesion in this ball sport?
It's difficult to reinforce ligament. As you can see, one of the most strong ligament is the radial collateral of the MCP joint, while to avoid on the grip, and the ulnar collateral is 42 kilo for the MCP of the index and 36. For the volar plate of the PIPJ joint, I told you is 19 kilos, so it's impossible to strengthen, and you don't have any muscle to make more strong at this level. No, it's, you know, if you pass the strength, the tensile strength of the ligament, you will turn it. It's biomechanical.
Yeah. So I don't think we have more questions, because I noticed all my questions. We check if there is anything else. I was, you know, I didn't know. So you calculate, you simulate for Dubai or Emirate. So it means 3,000, if you can repeat as a conclusion, because it's interesting how it is a huge topic, and we need to treat them correctly. 3,500 sprains and 1,000 dislocation. It means
for all the UE.
per year in UE.
Yeah, it's based on the study that said it's maybe underestimated, because one of the patients are not coming in the emergency, they reduce themselves, and that's it. For the finger injuries, for example, the simple finger injuries, laceration and everything, it's 250 per 100,000 per year. So it's almost 8 times more than the finger sprains.
Yeah.
So it represents, if you want, almost 25,000 hand injuries, wound injuries on the hand.
Yeah, it's huge.
It's quite common. These injuries are most of the time underestimate. I don't see all of them, because I'm not in the emergency, and the emergency will not send me all the strain if the patient are coming, the sprain, sorry, if the patient are coming. But yes, it's really important, because I've seen a lot of patients with 2, 3, 4 months injuries with complex Bouttonière deformity, with PIPJ joint retraction, instability. And it's a little bit sad, because this patient should avoid to have a surgery, but because it was misdiagnosis, underestimate, or because the patient didn't went to a doctor, they have a big sequelae, and the sequelae are totally different to treat than the primary sprain or dislocation.
And so, you know, based on the frequency of this and the incidence of this lesion, I think you cannot see everyone, but I would recommend to the people, if they want to have an advice, and this is what we do all together with this WhatsApp app, which is fantastic for that, to send the picture and some information. And already, it's not a clinical examination, but at least you can give the best advice for a sport. Can you do just a mobilization, or if you need to examine the patient to rule out any severe injury, which could be surgical, I believe.
Yes, but you know, when you're a surgeon, like for shoulder or knee surgeon, you prefer to see the patient and examine to have your own advice, because there is so many small testing, and you have the feeling, you will judge the x-rays, and you will take the appropriate decision. Because here it was a long topic. I went sometimes a little bit fast for some rehabilitation, so you will find on the YouTube channel, and you can have time to review everything. with the first webinar that I did, you will have grossly all the soft tissue injury of the finger and of the fingers. So yeah. It's look quite small joints, small injuries, but we did 2 webinars about that injuries.
So it will be a good conclusion. So I will say, tell the people who didn't have the time to look at live, they can always go back or watch your 2 videos. They will have a fantastic summary of the majority of the spot injury and different injury on the hand. And if you have any doubt, send the patient to Dr. Bernard Lallemand. He is here for that. This is his job, and he came to DXBond for that. I think it's important to mention that. Thank you, Bernard. We can close the session. I will ask you to reserve in 2 weeks your Tuesday between 6 and 7, and we will have a guest speaker, Jean-François Co, who is coming from he's from Belgium. He's a big specialist of PRP tendinopathy. He's well known in this field. He did a lot of science and research, and he will talk about the PRP and tendinopathy. And I hope at the end we will have an answer on this topic, which is completely controversial with different opinion. And I think Jean-François Co is probably one of the best to give us objective and scientific answer for this topic. So thank you very much. We will let you go back to your family, and thanks for attending. See you later.
Bye-bye.
Bye. Bernard, thank you very much.
It's a pleasure.